a very good evening and a warm welcome to one and all present here. I am Devolina from Clarinet. Clarinet is India's largest live digital CME and doctors generated medical content platform. So now, without taking much time, I would like to hand over the session to Dr. Muralidhar Kanchi sir, who is the moderator for our today's session. Dr. Muralidhar Kanchi sir is the Director Academic at Narayana Health City. Sir is Professor and Senior Consultant, Department of Anesthesia and Critical Care. He is also the Principal of Narayana Rujala Institute of Allied Health Science. So now the session is over to you, sir, for the next proceedings.
Thank you very much, Devolina, for that kind introduction. I am greatly delighted to invite you for this webinar. Thank you for joining the ICA webinar, which is a quality academic program. As you know, that Indian College of Anesthesiologists was established in 2008 under the able leadership of Manorama Mittal, Dr. Manorama Mittal, and now currently the leadership is taken over by Dr. B.R. Radhakrishnan, ably supported by Dr. Jayashree Sood, Baljit Singh, Dr. Belani. And today we have a very exciting session. Today we have a very exciting topic of coagulation and management. Sometimes we encounter bleeding patients in operating rooms and critical care units and trauma centers, and we do everything possible, but still patient continues to bleed and it becomes a nightmare to manage such patients. To tackle such problems, we have the experts in this field deliberating on the subject, and to moderate this session, they will also act as panelists. We have Dr. Sampada Gupta. Dr. Sampada Gupta is a very accomplished anesthesiologist, having received the President of India Award in Science Congress 2012. And she's one of the few PhD doctors in anesthesiology. I did not know that a lot of anesthesiologists have PhD. She's one of the few PhD holders in subject of anesthesia. And the second moderator panelist is Dr. Anita Shenoy. She's also very well known in the field of anesthesiology. She's a professor at Kasturba Medical College, Manipal. And the third moderator panelist is Rekha Das. Again, another accomplished person in the field of anesthesiology. And she's extremely talented and very well respected in the academic circles. With these few words, I would like to hand over the session to Dr. Sampada Gupta to carry on the proceedings. Dr. Sampada Gupta, please.
Very good evening to you all, sir. I am expressing my deep gratitude to you for calling me here in this August gathering. Yes, without delay, I want to call upon Dr. Swapnil.
I must thank the organizers of this wonderful webinar, which is, I think, a regular educational activity from ICA. So let me begin with my presentation, which is on physiology of coagulation. Now, when we talk about coagulation, it's basically a balance between the two systems, right? So since we have a pressurized vascular system, okay, whenever the vascular system gets injured, the blood flows out, okay? So the first step in any coagulation system is to prevent the further blood loss. And therefore, few factors work in favor of that, which are known as procoagulant. While on the other hand, some other factors maintain the fluidity so that this process of coagulation is not carried away all over the body, and we did not have thrombosis or the thrombi being generated all over the body. So those are called as anticoagulants, which are mainly maintaining the fluidity of the blood, right? So if we this whole process of coagulation is analogous to a sort of a drama, which is mainly anchored by three heroes and supported by multiple side heroes. right? So which are the three main heroes of this whole drama? Okay, so we have coagulation proteins, which also are commonly known as clotting factors, which have platelets, which are your primary megakaryocytes, and we have a vascular endothelium. These three are the main propagators of the coagulation, or the main initiators of the coagulation system, which then activate a certain other number of factors, which eventually lead to a platelet plug formation. So we are going to see step by step how each of these factors contributes, how each of these factor works. So to begin with, whenever there is a vascular injury, the first trauma occurs to the vascular endothelium. Okay, and this vascular endothelium, beneath this vascular endothelium are hidden number of factors, which are then exposed to the flowing blood. And these factors include tissue factor and von Willebrand factor. Now, these two are the main factors which are involved in the coagulation process. Okay, once we come to the coagulation cascade, we'll come to know how each of these factors play a role, right? The second fiddle of this coagulation process are the platelets. Okay, so as soon as as we all know that platelets are sort of floating in the blood, as soon as they come in contact with the von Willebrand factor and the tissue factor, what basically happens is the first step is the adhesion. So these are the platelets adhere to the site of the injury. Then the second step is activation, where the platelets liberate certain number of certain number of proteins and certain number of factors which are expressed on the surface of the proteins, which lead to aggregation of these platelets. And these platelets aggregate together, initiate the coagulation cascade, and that then generates the fibrin, which then forms the platelet plug. Okay, so this is the process of formation of a platelet plug. And the third factors which are important for the coagulation are the coagulation factors. Now we know that there are around 13 coagulation factors. Okay, each one of them has a different name. We know that some of these factors are dependent on vitamin K for their carboxylation. These factors are 2, 7, 9, 10. So these factors, if there is vitamin K deficiency, these factors will not be produced. The primary region where these factors are produced is the liver. Okay, but some of these factors are also circulating. For example, calcium, which is factor 4, or tissue factor, which is expressed by the endothelium. Okay, so some of these factors are produced by liver, some of these factors are already present and circulating in the blood. Okay, now when we look at all these factors, the thing that we need to consider is how long are they going to act. And the factors like factor 7 and protein C, these have the very short half-life. If you see their half-lives, they are roughly around 3 to 6 hours. So they have a very short half-life. So if they are out of if there is a liver dysfunction, factor 7 is not produced, then you may have a major derangement of your coagulation system. Okay, now let's comes to the whole process of coagulation. Okay, now it's something like an orchestra where different musicians have their roles, individual roles. If any one of them go wrong, the whole music sort of gets spoiled, right? So all of them had to work in a synchrony to achieve the desired effect, right? Okay, so this is we all know about the cascade model of coagulation, in which we used to learn this during our MBBS times, that factor 7 gets activated first, which when it comes in contact with the tissue factor, and that kicks the extrinsic pathway of the coagulation, whereas the intrinsic pathway is by the factor 12, which sort of activates factor 11, 9, and then factor 10. And ultimately, there is a common pathway in which factor 10 is converted to factor 10A, which in presence of factor 5 converts prothrombin, that is factor 2, to thrombin, and then thrombin converts fibrinogen to fibrin, and that forms ultimately the fibrin mesh. Okay, so this was a very common model which was followed and which was understood, which was studied over so many years. Okay, but in 2000, early decade of the 21st century, this model was challenged. Why it was challenged? because this model couldn't explain a few findings. What are those findings? This model couldn't explain why the bleeding is not seen when there is a deficiency of factor 12. So if there is a deficiency of factor 12, the intrinsic pathway is not going to act. But still, clinically, these patients, they don't suffer from bleeding. At the same time, there are a few other factors like high molecular weight kininogen or prekallikrein, which are also, if they are deficient, that doesn't matter. Okay. Whereas certain factors like factor 9, factor 8, and factor 7, if they are deficient, that leads to severe bleeding diastasis, which is completely out of proportion, even when your intrinsic pathway is intact. So somewhere this cascade model fails to explain the few findings, and therefore what is proposed nowadays is a cell-based model. Okay, and this cell-based model goes through the 4 phases. The first phase is initiation, followed by amplification, followed by propagation and termination. Now we are going to see each of these phases and what happens in each of these phases individually. So the first stage is the initiation. So what happens whenever there is an injury to the endothelium, it exposes the subendothelial tissue factor and subendothelial von Willebrand factor to the flowing blood. Now, this von Willebrand factor binds to the glycoproteins which are there on the platelets, which leads to a platelet adhesion. And this is how the platelets adhere to the site of injury. Whereas the tissue factor binds to factor 7, which activates factor 7, which in turn activates factor 9 and 10, and that forms something called as the initial extrinsic complex. Okay, so this complex generation is the most important step in the whole coagulation cascade, right? Now the next step is the amplification. Okay, so we all know that this sort of process of initiation and amplification generates thrombin. Okay, and this thrombin sort of then binds to the glycoproteins which are expressed on the platelet surface, activates a series of factors, and ultimately leads to a fibrin generation. But this thrombin, which is generated by the initiation and the amplification process, is in very small amount, is in very small quantity, which is easily inactivated by thrombin inactivators, which are circulating in the blood. Therefore, this process needs to get propagated, and there lies the next step of coagulation, which is called as propagation. Okay, now in propagation, what happens is factor 8A binds to factor 9A, which forms the intrinsic kinase complex. So we just learned about extrinsic kinase pathway, kinase complex, which is mainly a factor 7A, 9, 10, and tissue factor. Now, in addition, there is an intrinsic kinase complex, which is mainly made of factor 9A and factor 8A. Okay, and this then stimulates a large amounts of factor 10A. Okay, so this process of generation of intrinsic kinase complex and extrinsic kinase complex are quite important to generate large quantity of factor 10A. Okay, and this then factor 10A in combination of factor 5A produces a prothrombinase complex, which then stimulates the conversion of prothrombin to thrombin and fibrinogen to fibrin. Okay, so this thrombin, which is created, which is nothing but factor 2, which is created, which is activated by prothrombinase complex, then converts fibrinogen to fibrin, which is then sort of traps the platelets by GP2B3A receptors and then forms a platelet plug. Okay, so this is the whole process how the platelet plug is formed. Okay, so this particular cell-based model explains why the process of coagulation is localized. Why? Because this whole changes, they occur only where the subendothelial injury has occurred. Okay, so these changes do not occur where the injury is not there, and therefore it definitely explains, you know, why the thrombosis occurs at the injury site and why not it occurs at all the sites in the body. Okay, now, so the main crux or the main hero in whole of this process is nothing but thrombin, which is nothing but generated from the prothrombin to thrombin. So this is factor 2, which is also known as activated factor 2. which then converts fibrinogen to fibrin and then sort of links the platelets in between and forms the clot. Okay. The next step is also quite equally important. Whenever there is injury occurring, it should not only create thrombi, but it should also be able to dissolve the thrombi once the injury factor or injury threat is away, right? And this is basically the termination of coagulation process. This is again sort of process in which the thrombi are dissolved and the fluidity of the blood is maintained. Okay, so this is the main actors in this process are three. One is heparin sulfate, which is present again subendothelially, which activates which forms a conformational change in the antithrombin, which in turn inactivates factor 2A, that is thrombin, and factor 10A. Okay, so this heparin sulfate, which is present subendothelially, inactivates factor 10A and 2A. In addition, the thrombin also binds with the thrombomodulin, which induces a conformational change in thrombomodulin, which then activates protein C, and in presence of protein S, therefore both of them together, that is activated protein C plus activated protein S, inactivates factor 5A, right? So these two substances, heparin sulfate plus thrombomodulin, inactivates 10A as well as 5A. In addition, there is another factor which is also called as tissue factor pathway inhibitor, which sort of inactivates the extrinsic kinase complex, and therefore all the activated factors which are very influential in forming a clot, they are inactivated. So factor 10A is inactivated, factor 5A is inactivated. In turn, it terminates a prothrombinase complex, and therefore it restores the fluidity of the blood. Okay. Now, the clot that has been formed is formed by the platelet plug which is intermixed with the fibrin mesh, and the strength of this clot depends on the calcium concentration, because calcium is required for all these processes to happen. The pH, that is, if it is severely acidotic pH, then the whole formation of clot is disrupted. If the platelets are less in number, again you have the problems with the platelet plugs, where the platelet plugs won't be strong enough. It also depends on the fibrin diameter, the geometry of the fibrin network, and the local thrombin concentration. So all these factors are basically the determinants of the clot strength. So if you have deficiency of clotting factors, deficiency of platelets, acidotic conditions, hypocalcemia, that's when the whole process of coagulation is going to get derailed, right? So whenever we have patients with a major sort of blood loss, what we need to ensure is that they should not suffer with all these sort of scenarios, right? Lastly, once the fibrin has been generated, platelet plug has been formed, but the injury is now away. Now there's the very important process of fibrinolysis, because otherwise the thrombi would block the vessel and would block the perfusion of the subsequent organ, right? So this process of fibrinolysis is initiated by two main mechanisms. One is again the endothelium, which generates tissue plasminogen activator, and there are monocytes and macrophages which are involved with the inflammation, which also generate the urokinase plasminogen activator. So this TPA and UPA both activates plasminogen to plasmin, and then this plasmin sort of degrades the fibrin and forms the fibrin degradation products, which are also known as FDPs, right? So this is how the process of fibrinolysis occurs, where the plasminogen is converted to plasmin, which breaks down the fibrin to FDP. Okay, and this whole process is initiated by TPA and UPA, which are the plasminogen activators, but simultaneously there is a check on the activities of TPA and UPA. Okay, this is mainly by the plasminogen activator inhibitor. So what we understand is, to all the factors which are there, which are procoagulants, the body has also created some of the anticoagulant factors. Okay, and it's the balance between the two factors that determines ultimately which way the patient is heading, right? So this is all about the process of coagulation which happens. Now, obviously, it does have a lot of clinical implications whenever these factors are deficient, whenever the liver is malfunctioning, whenever there is platelets which are sort of either they are poorly functioning or they are lesser in number. That's when the whole coagulation system goes for a toss, and we may encounter severe bleeding, okay, which may even cause a significant amount of blood loss, okay. Commonly known situations like hemophilia A, hemophilia B, which are there mainly because of the deficiency of factor 8, factor 9, hemophilia C because of the deficiency of factor 11. So all these are the autosomal disorders which ultimately are there because of the deficiencies of all these factors, right? Now, one thing you must understand is you don't require all these factors to be present in 100% amount. Okay, roughly even a 30% presence of these factors can maintain a smooth coagulation system. Okay, if the percentage of this presence of this factor goes down below 30%, that's when clinically the process of coagulation goes for a toss, right? And if the factors are less than 5%, that's when there are severe hemophilias or severe bleeding diastasis. Okay, so again, what we need to understand is even a poorly functioning liver, which is generating some amount of factors, can maintain a coagulation system. But when the liver completely fails, that's when the factors they are completely they are less than even 5%, and that's when you have the major bleeding diastasis. Also, the vitamin K is required for the carboxylation of the carboxylation, which is involved in activation of factor 2, 7, 9, 10. Okay, and this carboxylation is very important process. If the vitamin K is not there, then this carboxylation doesn't happen, and then these platelets or these platelets they don't have the ability to bind to the calcium, and therefore then the process of coagulation gets interrupted, right? So if there is a severe deficiency of vitamin K, either because of obstructive jaundice or because of the nutritional, then again the coagulation process goes for a toss. Okay, the treatment for the same would be either a replacement of vitamin K or replacement of the factors. Okay, and nowadays many of these factors are recombinantly produced. So if you have a particular factor deficiency, that can be that patient can be managed with a supplementation of that particular factor. Just that these factors, the recombinant productions of these factors is a costly process. For example, factor 7, which is also known as a Novo7, is quite costly. Okay, but it is definitely available, and in a severe bleeding diastasis, we can use these particular factors as well. Okay, so with that, I conclude my talk, and I thanks again all the organizers for giving me this opportunity, and I'm very happy to receive the questions. Thank you.
I think we're having the questions at the end of the presentations. I think so.
Yes. It's at the end of the presentation.
So that was a very lucid presentation, Dr. Swapnil. Fascinating topic. And orchestra, definitely, indeed. It is an orchestra, isn't it? What happens in the body. I'm sure the audience was immensely benefited. Lovely lecture. I enjoyed it thoroughly. Thank you, Dr. Muralidhar, for giving me this opportunity to be part of this webinar. It's my pleasure now to introduce Dr. Alok Samantrai, Professor and Head, Department of Anesthesia and Critical Care, SWIMS, Tirupati. I had the good opportunity to know his predecessor very well, Dr. M.H. Rao. It's a pleasure for me to have met you at least online for now. Dr. Samantrai, as you can see, is MD, PDCC, PG, DDM, even ITC Coordinator, American Heart Association. He's going to tell us about blood conservation techniques. Over to you, Dr. Alok Samantrai.
Thank you, madam, for kind introduction. And without wasting much time, let me start my topic, and let us start with what is blood conservation first. Blood conservation is something as defined by the WHO which requires a reduction in the allogenic transfusion. Blood preservation is something which looks for alternate to the blood transfusion and also appropriate blood component therapy. All the three components were included under the blood conservation as per the WHO definitions. So how we achieve these things? This thing can be achieved in the intraoperative period, either by reducing the blood cell loss or by making the patient so much comfortable with the blood cell that during the surgical period, he can afford to lose some blood without requiring for a allogenic transfusion. Let us see how we can do that. Among the clinicians, perioperative blood conservation is widely practiced before, during, and after surgery. This is because not only it reduces the allogenic transfusion, but also it results in fewer infection rate, faster recovery, and early discharge. And all these things are one of the component, whatever strategy you try to employ in your hospitals. That is the reason why many clinicians are nowadays favoring a blood conservation protocols in their hospital. Let us see what we can do either before or after or during the surgery. Before surgery, we have three options.
Dr. Alok, can you please, slides are not changing. You will have to go for slideshow, I think.
The before surgery, we have three options in which we can conserve the blood. One is either you can go for nutritional supplement along with a specific medication to improve the erythropoiesis. That we can do by giving the recombinant derived erythropoietin to stimulate the RBC cell mass. This is appropriate for the patients who come with less than optimal RBC. That means their RBC is somewhere below 11 gram percentage. The second option is something which works just like what is a traditional bank does. That means the patient goes to the blood bank, donate the blood, reserve the blood, and whenever he needs it, he gets the blood. We'll go through this in the next slides in much detail. And the third one is just looking at the different drugs that the patient might be on, which can interfere the patient's hemostasis in the intraoperative periods. The basic problem with all this type of technique in the before surgery period is the patient needs several hospital visits, whether to receive his apoptosis or to receive or to donate the blood in the blood bank. The patient needs to visit the hospital several times. That may not be convenient to each the patients. And the second is all this has a lag time. That means the patient has to wait for his surgery at least for 5 to 35 days. That means if you are going to change or something, bring something in anticoagulant, antiplatelet medication, then the patient has to wait for 5 to 7 days. And the patient is going for a blood donation, then he has to wait for 21 to 35 days so that the enough amount of blood is collected in the blood bank, which can be used in the intraoperative period. The problem with the recombinant erythropoietin treatment is patient might have some thromboembolic event in the perioperative period, which is a major concern with this type of therapy. Let us look into the preoperative autologous donation. Here, actually what happens is the patient comes to the hospital who has a more than optimal amount of RBC. That means the patient's hemoglobin and hematocrits are in the range of 11 to 12 gram percentage, and the patient do not have any significant cardiovascular and pulmonary comorbid condition. And the patient has a requirement of transfusion by more than 10%. So here the patient donates his blood once or twice weekly before the actual surgery date, and the last blood that is drawn from the patient is at least 3 days before the actual scheduled surgery, so that the patient gets enough time for compensatory erythropoiesis. The very limitations for this preoperative autologous donation is, which is not desirable at all, is many of these patients, they develop postoperative anemia. Because even if the compensatory erythropoiesis takes place, it does not completely compensate for the RBC mass which is lost in the form of donation. It only support up to 60%. So the patients after donating blood in the perioperative period or immediate postoperative periods, the patient become anemic, and this makes what the patient again needs allogenic blood transfusion. So although preoperative autologous donation reduces the allogenic blood transfusion, completely does not eliminate the requirement of allogenic blood transfusion. Second is, this type of patients, usually they blame the hospital if there is some complications while donating the blood, because it's the doctor who convinced them to donate the blood before the surgery. Why this thing happens? Unlike a normal blood donation where a completely healthy patient comes to the donate the blood, these patients are sick in 1 or 2 systems. When they donate blood, the risk of complication is 12 times more than the normal donation. The most major problem, which is not proves to be very much beneficial, is we cannot actually predict how much blood the patient need to donate in the preoperative period and what is the actual demand of the patients in the intraoperative period. So what happens, sometimes the patient donate the blood which is not at all required during the intraoperative period. In that point of time, it leads to discarding the blood which is collected, because as per the certain rules, we cannot transfuse it as a allogenic transfusion to other patients. And the fourth most important thing which is concern which is coming is this preoperative autologous donation in cancer patients. It was seen that the cancer patients, if they are donating in the preoperative periods, there is an increased chance of cancer recurrence. So these are the few limitations of the preoperative autologous donation. During surgery, we have 4 things that we can do to preserve the blood. Several strategies will be there which will be applied by the both surgical team and anesthesia team. But we will look into these 4 techniques which is widely practiced and which are having sound evidence that they helps in preserving the blood. The most commonly practiced is acute normovolumic hemodilution, controlled hypotension or permissive hypotensive anesthesia, cell salvage, and different pharmacological therapy which prevents bleeding in the intraoperative periods. Coming first to the acute normovolumic hemodilutions. Here, this is again a type of autologous blood donation only. But here what happens is, instead of the patient going to the blood bank to donate the blood, the patient donate the blood on the operation theater table. That means either just before anesthesia induction or immediately after anesthesia induction, certain amount of blood depending on the patient's preoperative hematocrit and body general metabolic status is drawn into a anticoagulated bag. And the patient bleeds as usual or with certain conservation technique, the diluted blood. And this blood which was collected in the pre-surgical periods are replaced with acellular fluid. Usually crystalloids will be replaced for the blood which is drawn from the patients. So at the end of the surgery or once the major bleeding ceases, this blood which is collected in the just pre-surgical period is transfused back to the patients in the reverse order. The indication for this type of autologous donation is when the likelihood of blood loss is more than 20% of the estimated blood volume. The patient should have at least a preoperative hemoglobin of at least 12 grams per deciliter without any significant cardiovascular and pulmonary comorbidity, and there is absence of infection and risk of bacteremia. The benefit of this, because a certain amount of blood is just removed before the surgery starts, it decreases the viscosity of the blood. That helps in a free flow of the blood and it improves the tissue perfusion and thereby oxygen delivery. Second is what we have seen in preoperative autologous donations, the clotting factors, all those things, they are no more available when the patient actually uses the blood in the intraoperative period. But here, because the blood is donated in the operation theater itself and getting reused by the patients within 8 hours, most of the proteins, blood component, coagulation,
no cross match,
available
no
with the patient.
testing, no clerical error.
So this blood again doesn't require any cross-match testing and there is limited risk of the clerical error. The only risk associated with this acute normovolumic hemodilution is while taking 1 or 2 unit blood, there may be sudden decompensation of the patients if patient is not properly evaluated. So there is a sudden hemodynamic changes, so that need to be tackled by appropriate acellular fluid transfusion. The next technique that we can use in the intraoperative period is cell salvage technique. This technique is nothing but collecting the shed blood. That means it does not even allow the surgery to be interfered. That means in the preoperative, this acute normovolumic hemodilution, before the surgery, the surgeon has to wait for some time till the blood is collected. But here that is also not required. As the surgery go on, there is bleeding from the surgical site. That blood is collected and need to be processed so that a concentrated amount of RBC can be collected back at the end of the surgery, which can be transfused back to the patients. The advantage of this technique is this can be used not only for elective surgery, but also for emergency surgery also the same technique can be used. But only thing is this is not as cost effective as acute normovolumic hemodilution because this requires a special machine to centrifuge the blood and give the actual RBC component. The indications are whenever there is anticipated loss of more than 1 liter or 20% of the estimated blood volume, there is increased risk factor for bleeding, and patients with rare blood groups and antibodies. And I think this is the only type of autologous blood donation, which is accepted by the Jehovah Witness. The benefit of this cell salvage therapy is it does not involve manipulation of patient's physiology. That means either in ANH or PAD, there is a risk that while at the time of donation, but here that risk is not there because it's the normal process. The surgery is going on and the blood is only collected into a separate reservoir. The second is it is not affected by the cancellation of the surgery. What happens in the pre-operative autologous donation? If the surgery is cancelled for some reasons, then most of the blood which is collected, at least the first unit of blood which is collected, it got expired. The lifespan of the blood get expired. So those type of risk is not available in cell salvage technique. The limitation of cell salvage technique is usually it is not indicated or relatively contraindicated in patients with infection and malignancy, but with the use of leukocyte depletion filter, the risk of infection can be reduced up to 99%. But again, in the patient surgical site, some metal is being used as in the orthopedic surgery and all those things. It cannot distinguish this small metal fragment that also gets sucked into the centrifugation process. So it's always better to use two types of suction catheter. One dirty catheter, which can be used when they are doing this type of suction, when the metal fragment is used, and the rest of the times they can use a clean catheter where the blood will be sucked into the reservoir vial where it will be centrifuged. Second is the recurrence of cancer risk is minimized in this. That means in cancer patients also this technique can be used, but only thing is you have to use specialized blood bags which will be subjected to irradiation to remove all the tumor cells. If this technique is used in the post-operative period, probably there is a risk of coagulation abnormality or risk of kidney failure, because mostly in the post-operative periods they use a process where the RBC are not washed and transfused back to the patients. The second limitation is again, this technique will not be cost effective unless at least you are collecting at least more than 2 units of blood in the intraoperative period. That is the reason some centers, they do not start the centrifugation process unless at least 700 ml blood is collected in the reservoir vial. The next technique is induced hypertension, most favored by the anesthesiologist. Here we know that apart from the duration of the surgery, the next thing that can give rise to increased bleeding is the rise in the blood pressures. So here the blood pressure is controlled to a systolic blood pressure of around 80 to 90 and a mean arterial pressure of around 60 millimeter of mercury by either giving deep anesthesia and analgesia, but that delay the patient's recovery once the surgery is over. So many people resort to a moderate amount of anesthesia and they use vasoregulatory drugs to bring down the blood pressures and control the heart rate so that the bleeding is minimized. The basic problem with this technique is even with a safe range of hypotension, one cannot completely eliminate the risk of brain damage, stroke, and sometimes even the cardiac heart attack may happen. And in few surgeries where there is a prone positions, there may be a risk of end-organ hypoperfusion resulting in either ischemic optic neuropathy or acute kidney injury. So this technique may not be suitable for a very long surgery, but for moderate type of bleeding and in a specific group of patients without any other cardiac pulmonary comorbidity, this technique will be very much helpful. The other things that can be used during surgery is giving a pharmacotherapy. Either you can use antifibrinolytics like tranexamic acid, aminocaproic acids, kallikrein inhibitors like aprotinin, desmopressin. My previous speaker has told about the Novo 7. Local anesthesia, vasoconstrictor, all these things in some way reduce the bleeding. Even a misoprostol rectal, where we are considering that there will be risk of PPH, also can reduce the bleeding. And just giving local anesthesia and vasoconstrictor before putting a scalp incision also can reduce the bleeding. These are the few general techniques that is widely accepted by all the clinicians, which in some way reduces the bleeding. May not be a big amount, but still it will be a part of the blood conservation technique, like positioning the patients, the surgical part above the heart level, reduces the venous pressures. Just keeping the abdomen free in the neurosurgical positions reduces the venous pressure and reduces the bleeding. Central neuroaxial blockade by having a better control of the heart rate and blood pressure reduces the bleeding. 1 degree centigrade decrease in temperature increases the loss of blood up to 1 unit. So a normal temperature is always desired to as a part of blood conservation strategy. Minimal invasive surgery compared to open surgery is always preferred. Tourniquet, whatever advantage you may get with tourniquet, that may be completely compromised if the surgeon asks to open the tourniquet to check his hemostasis before wound closures, then that benefit of tourniquet may get compromised. Topical hemostatic agents, like it's just a combination of a mechanical collagen or foam or gel foam along with the thrombin agents. These are also helpful to certain extent. Using of a higher technical bipolar sealing device, harmony scalpel, this also reduces the bleeding to certain extent. After surgery, basically pressure dressings, pharmacotherapy, cell salvage, and point of care testing, they are helpful in preserving the blood. Pressure dressing, we know that this is definitely it is a natural way of stopping any sort of bleeding. Pharmacotherapy, same tranexamic acids, kallikrein inhibitors, all those things may be continued in the postoperative period to have a better control of bleeding. Postoperative period also, cell salvage technique can be employed through the whatever blood we get from the through the drain, that can be retransfused after washing the RBC to reduce the risk of AKI. Regarding point of care testing, I think my next speaker will tell much more about this, how this point of care testing will be helpful in preserving the blood loss or providing appropriate blood products so that bleeding can be stopped. To summarize, every hospital should develop a blood management program for individual surgery. One should always look for a setting for a low transfusion triggers, unlike the older days transfusion trigger of 10 gram percentage with the 30% hematocrit. One should go aim for 6 to 7 gram percent as a transfusion triggers, unless the patient has other complications. One or two technique in combination always helpful than a single technique. Pharmacotherapy, acute pneumovolemic hemodilations, these are low-cost technique that can be utilized almost for all the cases, elective and emergency cases. Self-salvage technique has much promising results if the hospital has appropriate infrastructure for the same. Thank you. And I'm sorry for the disturbance, whatever happened in the middle, and I thanks the ICA for giving me the opportunity.
Very comprehensive lecture, Dr. Alok. And very, very useful points. Thank you so much. Very nice lecture.
So I shall be taking over. Or what? So shall I take over now?
Yes, Doctor. Yes.
So that was a very nice and comprehensive talk by Dr. Alok Samantray on blood conservation techniques. I think he has covered practically everything about it during the perioperative period. So now we move over to our next speaker, who is Dr. Puja Natarajan. She is the consultant cardiac anesthetist from Narayan Hridayalaya Hospital. She has a list of qualifications as MD, FNB, FICTA, FICCC, FASC, NB, Testan, some of which I do not know actually. So, and she is a faculty at the national and the international TE and in the anesthesia conference. She has 6 publications, international and national, to her credit, and her areas of interest are aortic surgery, transplant, VAT, and ECMO. With this, we now request Dr. Puja to kindly give a talk on viscoelastic techniques, which is a very upcoming subject, and we must all get to know how to do it, and we must also try to procure it. Now, Puja, you can share. She has started sharing her slides.
Thank you for the kind intro. Thank you for the kind intro. Thank you everyone for giving me an opportunity today to talk on viscoelastic testing. So to keep it short, viscoelastic testings are point of care coagulation tests, and these are bedside monitoring tests which are available, unlike the olden days where we used to send the blood to the laboratory to get the test done, and it used to take a lot of time. But thankfully, we have all these small gadgets which are available next to our OT, and whenever there's a massive transfusion happening, and we can give evidence-based algorithm guided transfusion, and specific platelets, fibrinogens can be corrected by knowing how to read a trace. So this was described by Hartert almost in 1948. That's quite long ago. And this is very unique because we can visualize the trace live, unlike in the lab where we don't know what's happening. here we can see how the clot is formed, organized strength, and even lysis can be visualized. So it's very fast, it's handy, and whole blood is used. And as I said, it is evidence-based algorithms can be used, and anybody can do it. But again, to talk about the disadvantages, we measure the coagulation under artificial conditions in a cuvette. So it can be a little dicey, and a little training and competency, of course, is required. And the rigorous quality assurance which is done in laboratory may not be done because it's there in the OT and nobody will come down to, take care of it. And it's quite expensive. So as Dr. Swapnil said, these are the parts. Am I audible?
Yes.
Thank you. These are the pieces of coagulation which will be monitored separately. And as a cardiac anesthesiologist, I am very much concerned about the factor 1, that's fibrinogen, and the factor 7, and the factor 13, which is like the forgotten factor. But to remind you all that the cryoprecipitate has a lot of factor 13, and which can save us from massive bleeding. So to go to the coagulation pathway, as we know, we can in the ROTEM, we can look at intrinsic pathway and extrinsic pathway separately, and fibrinogen being in the common pathway, we can separately look into the fibrinogen levels, and then based on the levels, we can values, we can give cryoprecipitate transfusion and save the day. To have a background about the patient is very important, especially the history, the drugs patient is on, and the comorbidities like any chronic liver disease or kidney disease makes a lot of difference. And intraoperative factors, me being a cardiac anesthetist, the cardiopulmonary bypass is a machine which actually eats away all the coagulation factors, especially the platelets. So we need to keep in mind, particularly about the platelets and the fibrinogen, as I mentioned. Redo surgeries and the length of the surgeries is also important because of the temperature, hypothermia, and hyperfibrinolysis. So we'll talk about Sonocloth, TEG, and ROTEM.
Viscoelastic tests.
Yes. So let's talk about the Sonocloth. So Sonocloth is a machine where around 0.4 ml of blood sample only is required, and it contains a cuvette which has a glass bead activator and a heparinase, and it has a probe which vibrates a very high frequency, and Sonocloth signature is formed, and we interpret all the parts of the coagulation pathway based on the Sonocloth signature. I shall come to the details in the subsequent slide. The TEG and the ROTEM are almost similar. The only difference we need to know is the in TEG, the heated cups are the one which move very fast, and the pin is stationary. And this, when the fibrin strands are formed, this is the pin and the torsion wire. It is suspended in the blood, and the trace is formed, and this is processed into a graph by the data processor, and we'll analyze it eventually. And the amount of blood required is really minimal. So coming to the Sonocloth signature. So this is how it looks like. So the first phase is the activated clotting time. And the second phase, where the clot rate is what we look at. And the time to peak also is known as the platelet function time. So this is how a normal Sonocloth signature looks like. And there are many standard sensitivity and high sensitivity models which are available with platelet function and with heparinase, which will help us to differentiate when there is heparin in the patient's blood, and also when there is thrombocytopenia. So to analyze the Sonocloth signature, the first one will be the ACT. So that's the activated clotting time. So based on the activator used, there are different values, and these are the normal values which are available. And clot rate is the R1. So that's the primary slope, and this reflects how the fibrin formation from Fibrinogen happens. And this is the second phase where the fibrin combines with the platelet, and the interaction again strengthens the clot. And eventually the downward trend is the clot retraction, and this is again produced because of platelets induced contraction. So we should know the normal value, that platelet function, anything between 0 to 5 is normal. In this slide, we see that when there is a poor platelet function, there's a slow uptrending curve on the trace. So this is how a poor platelet function trace looks like. Next, coming to the TEG. So as I mentioned previously, in the TEG, the cup rotates, which has the blood, and the pin is stationary, and the torsion wire analyzes the TEG recording as the fibrin strand forms. So what's the difference between ROTEM and TEG? This is a modified version, obviously, ROTEM, and the activators in it are different. So in ROTEM, we can look at EXTEM, that is extrinsic pathway, and intrinsic pathway separately. Now, this looks scary, but over the period when we work with the machine, it's quite simple. So I'll keep it simple. The TEG is the upward trace, the bold trace, and the downward dotted trace will be the ROTEM. It is the same picture. It's just the nomenclature of the of each. The TEG and the ROTEM are different. Like for example, the R time is called the clotting time in ROTEM, and INTEM and EXTEM has separate values. So based on these values, the K time and the CFT, that's clot formation time. So based on these values, we will interpret as to which coagulation parameter is deficient, and we will correct accordingly. So the main thing which we'll be looking at is this MA and the MCF, which will talk about the platelets and the fibrinogen. This helps a lot, especially in cardiac surgeries, and we rely on this, and also the CT and the CFT when we give heparin. So we compare between the INTEM and HEPTEM, and based on the ratio, we will decide upon giving extra protamine or not. So this is a very simple slide, which will make all the questions, easy. So if the trace looks like a champagne flute, then we'll consider it to be low fibrinogen and give cryoprecipitate. If it looks like a test tube, then it could be low platelets and we'll give more platelets. And if it's like a martini glass, then fibrinolysis, and we'll think about giving tranexamic acid or aminocaproic acid. And if it's like a wine glass here, then it could be a factor deficiency. We'll look at giving FFP and prothrombin complex concentrate. So when I was learning TEG, this chart I used to have all the time on my mobile. So if the R time is prolonged, we give FFP. If it's K and alpha angle issues, then we'll give cryoprecipitate. And maximum amplitude, which corresponds to the platelet, we will give platelet and desmopressin. Desmopressin is also very helpful and helps in increase the von Willebrand factor deficiency. And lysis time, if that is excess, fibrinolysis is happening, especially on CPB, and we completely rely on our tranexamic acid to take care. Again, this slide might look scary because the ROTEM gives a lot of values, like the extrinsic pathway, which consists of the EXTEM. The FIPTEM tells about the fibrinogen. The APTEM verifying the effects of antifibrinolytic drugs. The INTEM with the intrinsic pathway. HEPTEM with the heparin. So these are the 5 things we do regularly. In addition to that, the platelet analysis is very useful, especially in patients who are receiving aspirin, clopidogrel, prasugrel, pre-operatively, and Aratem, Adaptem, and Traptem comes to our rescue. So pre-op, if the patient is on clopidogrel, so then pre-op blood evaluation of Rotem platelet analysis, and based on that, whether to take the patient to surgery has saved many lives. So I'll go in detail with the platelet functioning monitoring. So the platelet functioning analyzer 100, which is quite famous. And the uniqueness about this is that it is the function monitors by incorporating high shear conditions to simulate a small vessel injury and measures platelet adhesion and aggregation. And aspirin-mediated platelet dysfunction, which is very common, and also the von Willebrand disease. So these are the gadgets which are available for platelet function monitoring. And the TEG also has platelet mapping, and which can show the effects of aspirin and ADP. And this is how the TEG trace will look like. So going to the trace, the red line will show the Chiolin trace, the purple line represents the fibrinogen, and the green line represents the fibrinogen plus platelets, which responds to ADP. And there's something very blurred turquoise line, which represents the fibrinogen plus platelets, which responds to arachidonic acid. So we can see that the inhibition due to the ADP antagonism is 55.7%, and due to arachidonic acid inhibition, aspirin is 96.2%, and that's quite severe. Similarly, these are the different traces, especially patient on heparin. Whenever we add heparinase and the R time is much shorter and the MA increases, we know that heparin is there in the blood and we can give agents to reverse it. There are some percentage of inhibition is calculated by this given formula, and based on that, we will know how much of platelets are inhibited. So these are the bedside point of care coagulometry available. So we can measure the bedside INR, PT, APTT, especially on patients on vitamin K antagonists. So how do we manage? How do we apply clinically? This is what we face in day-to-day activity with all these blood products all around. So this Korean Journal of Anesthesia has this algorithm based guide for bleeding management. I think it's very helpful. I cannot cover this in this session, so kindly go through this. And this is how the chart looks like. So all we have to do is look at the various value, put these values in this, and look at what is required. So this is how we manage intraoperatively, and for separate for pregnancy related bleeding, for trauma, for sepsis, all the algorithms are different, and it comes very handy, especially in chaos situations. So what I would like to tell is some important points, like when we have a CT intem and a heptem ratio below 1.25, almost it was not associated with increased postoperative mediastinal bleed, because most of the time the residual heparin is which will cause bleeding post-op. So this is a very important thing which we look at. And protamine overdose, again, because we are thinking it's heparin overdose and we give protamine, that also can be dangerous because that reduces platelet, causes platelet dysfunction. And so we have to be cautious about that. So what they suggest is a ratio of 1:0.6 to 0.8, unlike the previous notion of 1:1 or 1:1.3. Now it's come to 1:0.6 ratio of heparin to protamine to be more effective. And again, the fibrinogen level, anything below 2 grams, the increased probability of bleeding, and that has correlated well with the Rotem values. and the CT extem of more than 85 predicts the INR to be more than 1.5. It's very good, these ROTEM, and it completely correlates with our lab values. So the evidence to do is given in all the guidelines. So no doubt that these are very helpful. But the pre-op testing, again, as I mentioned, it is very helpful in patients who are taking antiplatelets, but regularly nobody does it. And not to forget about the COVID, where it is a very thrombotic state, and POC has helped in these COVID patients also to help in blood management. Thank you so much.
Thank you, Puja, for that excellent presentation. And we will take the questions at the end of all the talks. So please stay back. Yes. And we'll go to the last talk of the day. And we have Dr. Arupratan Maiti, who is one of the leading anesthesiologists, and he is currently stationed in United Kingdom, Newcastle, and he's a promising cardiac anesthesiologist. May I request him to share the slides and give the brief on how he tackles the bleeding patient. The topic is patient is bleeding, what do I do? So Dr. Arupratan Maiti, please start this session.
Thank you very much for your kind introduction. So, just 1 second. Can you see my slides here, sir?
Yes, we can.
Yeah. Okay. Thank you very much, sir, and thank you very much, ICA, for giving me this opportunity. I'll be talking about the bleeding patient, and I have no conflict of interest. I have used a few trade names in my presentation, and which we use day to day, and but I have no biasness. There's no disclaimer. So before I start my presentation, I want to give some facts. Bleeding at 33 to 37 degrees are mostly due to platelet adhesion defect. But when it comes to less than 33, both platelet defect and coagulation enzyme defect happens. FFP is associated with transfusion-associated volume overload and also transfusion-associated acute lung injury. Fibrinogen remains the first component to critically remain low after massive hemorrhage. In 18 trials on a very large number of patients, desmopressin only could minimally decrease the perioperative blood loss. And it's a common fact that 1 unit of Prbc is expected to raise the hemoglobin by 1 gram. 1 pull-up platelet increases platelet by 25 to 35. FFP at a dose of 10 to 20 ml per kg increases the coagulation factors only by 10%. And if we give 5 units of single donor cryoprecipitate, it typically gives 1 gram fibrinogen. So basically, to manage or increase the coagulation factors, we need to use a lot of volume of the FFP and fibrinogen. So I have worked in the cardiac anesthesia for the last 10 years. And so I'll be giving example of a cardiac patient, how I do that. I have 2 basic goals. Once I do any cardiac case, first goal is that to stop the bleeding as soon as possible. Because the more the blood patient loses, he loses more coagulation products, and he becomes more coagulopathic. Eventually, he will need more volume, and surgery becomes delayed wound healing, and all these problems comes. Secondly, I try to use as less as blood products like FFP and cryo and platelet, because firstly, they have their own problems, own complications, and secondly, FFP and cryo can cause trally, infection, and TACO. So how I manage a cardiac case, just giving an example. So this is a 75-year-old male patient with a fibrosis of lung, is posted for urgent aortic valve replacement for infective endocarditis. So as you can understand from the case that he has a fibrosis of lung, so giving much volume can really jeopardize his lung. And at the same time, he's expected to bleed because he's infective endocarditis. So why cardiosurgical patients bleed? These are the few basic points why they bleed. I'm not going into details, but generally speaking, for any bleeding, I think either you do cardiac surgery or do non-cardiac general surgery, the principle for management of the bleeding, I think, is the same. There may be slight variation, but essentially it will be the same. So if you're anticipating blood loss, how to get yourself prepared? So what I do, I usually put a big bore peripheral line, 14 gauge or a 16 gauge, big introducer sheath, 10 French, of course arterial line. We use cell saver in all patients of cardiac surgery, and we have pressurized volume infuser and high flow multifuser in theaters. And the high flow multifuser can transfuse warm fluid or warm blood products 500 ml per minute. So in massive bleeding, that's a massive gain because you are essentially transfusing warm fluid 500 ml per minute. And we use warming cassette for all the patients for giving any fluid. So for this case, coming to this case, so usually I will order a baseline ACT, a FibTem, and a platelet function. So all these are point of care testing, and I also do something called the HepCon. So HepCon exactly tells me the arrow how much heparin I should give to achieve a ACT, good for the bypass, so that I don't use a very high dose of heparin and the ACT doesn't go very high and cause more bleeding. So this test is really useful. And for this case, I'll use aprocitentan infusion preferably. And if someone doesn't want to use aprocitentan, he can use tranexamic acid. So at the end of my talk, if we can debate about aprocitentan, I'm happy to do that. So next, surgery is being done. During the rearming phase of CBP, I usually routinely send a rearming blood for ROTEM sigma. And ROTEM sigma does all the 4 channels, extem, intem, heptem, and FibTem. And alternatively, I'll send a heparinase tag, and I'll send a platelet function as well, and do the same thing like HepCon for a protamine dose. So the HepCon not only tells you the heparin dose, it also tells you the protamine dose, because excessive protamine has its own significant consequences. And I shall correct any acidosis with bicarbonate during this time. So this is how the HepCon gives you value for the protamine. So you can see the heparin was 25,000, and the protamine needed is 168 milligrams. So it's quite low than expected. So you give the exact amount of protamine so you don't overuse the protamine and don't cause factor V inhibition and platelet dysfunction. And this is the rewarming ROTEM I get, and my interest is the extem A10 and also the FibTem, because fibrinogen is the first factor which gets critically low in any hemorrhage. So I usually check the FibTem A10 and FibTem MCF, and based on these 2 results, I correct the FibTem. So in any bleeding, my first aim is to correct the fibrinogen and then everything else, why I will say later. So this is the platelet function we get, and this is what it looks like. So you can see it gives a baseline platelet count of 159, and we do it by collagen aggregation. So it's a 58% aggregation, that means functional. So total functional platelet count is 93. So in this case, you see that although the total platelet count is 159, but the functional platelet count is 93. So the beauty of this test is that it gives you exact number. So you know exactly how many platelets are functional. And so accordingly, you treat that. So ROTEM and ROTEM also gives you qualitative number, but this gives you quantitative number. So I use both of them. So based on these results, I keep blood products ready. As I said, I don't want to use FFP or cryoprecipitate or platelet. We rather use other things which can be given more swiftly and more effectively. So I keep things ready: fibrinogen concentrate, prothrombin complex concentrate, which we use the beriplex, and the platelet if needed be. I do not order FFP at this time. So while first step after coming off, I use the protamine infusion as per the HepCon value I have shown you, and excess protamine can cause factor V activation, inhibition, and platelet dysfunction I have discussed. Once I have neutralized the protamine, then first thing is fibrinogen. So I transfuse fibrinogen if ATEM of XTEM is less than 45 and ATEM of FIBTEM less than 13. That is the cutoff point where I will transfuse fibrinogen. In that case, usually I give 2 vials of Fibriga, that means 2 grams of fibrinogen. And if the ATEM of FIBTEM is less than 10, then I'll give 4 grams of fibrinogen. So what we use typically, we use this Fibriga, and here it comes as a diluent and as a filter because it bubbles a lot and it's difficult to dissolve. So it comes as a filter. So you filter this solution and give it straight away. You can give it straight away. So like any blood product or cryo, and it gives 1 gram. The vial contains 50 ml, means 1 gram. And to achieve 1 gram of fibrinogen, if you give cryo, you have to use 5 units of cryo. So that's a lot. And so other way, so if you are not wanting to do that way, what you can do, just do the FIBTEM and check the FIBTEM NCF. And this is a formula by which you can calculate the gram of fibrinogen you want to give. So once I have sorted out the fibrinogen, then my next target will be platelet, if I need to give platelet. So again, ROTEM tells me XTEM and FIBTEM. So if the ATEM FIBTEM is more than 13, that means fibrinogen is fine now, but still ATEM XTEM is low, less than 45. That means patient needs platelet. Now the question is, how much platelet to give? For that, I have got the platelet function test, the numbers. So I get the functional number of the platelet, and accordingly I decide how many units of platelets have to be given. So if the functional platelet is less than 80, I give a pool of platelet, which increases by 25 to 30,000. That essentially means more than 1 lakh platelet. If the functional platelet count is less than 60, I use 2 pools of platelets, which essentially increase the platelet by 50 to 70,000. So again, more than 1 lakh. So safe for the patient. So now, very quickly, I have sorted out fibrinogen and platelets. So what next? And this is the platelet function. And then after protamine, I'll check the INR with the Coagulation machine, which is point of care. It takes just 1 minute to give you the result. I'll check the ionized calcium in the blood gas. I'll correct any acidosis. I'll check the hemoglobin, and I'll continue aprotinin infusion till the chest closure, or if I'm not using aprotinin, I'll repeat the tranexamic acid, and I will keep the patient warm. It's very important. So we use this cassette, warmer cassette, through which it warms the blood or any fluid instantly. Now, after checking the INR, if the INR is more than 1.3, and the clotting time in XTEM is high, and the patient is clinically bleeding, then I treat with the beriplex. So beriplex, usually if the INR is 1.3, less than 1.5, I'll typically give 1,000 units of beriplex, and with more than 1.5, probably I'll give 2,004 beriplex, which are usually more than needed for any patient. So by 15 minutes, I have given fibrinogen if needed, a platelet, and Veriplex. Veriplex also comes, you need to dilute it in 20 ml, and straight away you can give. So by 50 to 20 minutes, I have corrected all the coagulation factors. And in 15 to 20 minutes, there is hardly possible that the patient will bleed much. And that's why patient really bleeds quite less. And then the question comes, when I use the FFP? So in spite of giving the Veriplex, if the CT X-time is still high and the patient is still bleeding, then probably I'll use the FFP, because probably other factors are also deficient. And if the patient is bleeding loads and I need to give huge volume as coagulation factor, then I'll use FFP. Rarely we use FFP, honestly. So when to use cryoprecipitate? So because I have told you that I use Fibriga in all the cases, most of the cases of bleeding, but when to use cryoprecipitate? So I have given 4 grams of Fibriga. That should be enough for one patient. In spite of that, if I see that the ATEM of X-time is low, or ATEM of FIBTEM is low, or FIBTEM MCF is still low, that means probably we are dealing with a factor 13 deficiency, which is the last stage which causes fibrin monomer to polymerase to fibrin polymer. So at this point, even after giving 4 grams of fibrinogen, if the patient is still bleeding, potentially the patient has factor 13 deficiency with a low FIBTEM MCF or low FIBTEM ATEM, then I'll consider giving cryoprecipitate. And in extreme cases, if nothing is working, you can use factor 7A, but be alert, you can give 1 milligram of factor 7A, but it can cause fatal arterial thrombosis. And you have to be sure that you have corrected the acidosis and hypothermia before you use factor 7. It's a risky drug, honestly. So when do I transfuse PRBC transfusion? My transfusion trigger is less than 90 of hemoglobin, and in all cases we use the cell saver. And so by this, in 90% of the cardiac surgery, we don't use any unit of blood, PRBC. So with this protocol, we need any PRBC in more than 90% of the patient. Now coming to the intrafluid. So if there is minor to moderate bleeding, it can be managed with crystalloid. We usually prefer the plasma light because Hartmann or Ringer has the lactate, so it can increase the lactate. So usually we use the plasma light. But remember, if you are covering the blood loss with the crystalloid, you have to give 3 times than the blood loss, and the half-life of the any plasma, any crystalloid is low. It 10 to 15 to 30 minutes, so it can easily get third spaced. So any bleeding more than moderate, we use the colloid, and in all heart and lung transplant patients who need volume, always use 5% human albumin. So another practice which I don't do, but you can do, that when rewarming on CPB, when you check the clotting time on X-time more than 80 seconds and clotting time on HEP-time, which is more than 240 seconds, then some people transfuse the FFP on pump, or even give vitamin K on pump, which potentially reduces the bleeding post-bypass when you come up, but I don't practice this. So what surgeons use here, what we have. So there are plenty of things surgeons can use, but what your surgeons use, you have to know this very well. And why, if we have time, we can discuss at the end of my talk. So we have Oxytamp, which is basically the cellulose, and the fibrillary is nothing but the Oxytamp with the multiple layers. It comes as 7 layers. And we have Parklot, which is a thrombin powder, which is also known as cocaine powder in UK. It's a very good way closing the chest. And we have got FlowSeal, which is a hemostatic matrix with the thrombin, and we have got T-seal containing the thrombin and the hemostat and the fibrinogen as well. It's aproteinin. We have a BioGlue which contains fibrinogen. The beauty of the FlowSeal is that because it contains only thrombin, so thrombin can only interact when patient has adequate fibrinogen. So once the surgeon is using FlowSeal, If the fibrinogen level is low for the patient, it will not work. That's why we need to correct the fibrinogen first before doing anything. The thrombin comes into fibrinogen, clots the forms clot, and to flow seal to work, we need a flowing blood, because the blood flow comes and then the thrombin interacts with the fibrinogen of the blood, and then clot is formed. But the T seal, for T seal to work, you need to clamp, because it doesn't work on wet surface. You have to clamp the vessel, you have to make it dry, then put the T seal, because T seal has got fibrinogen and thrombin itself within and a protein in, so then it works very well. And bi-glue is the fibrin. So the patient has been done surgery very nicely. This patient has gone into ITU, has done well on post-op day 4, still got a chest drain because patient's pacing was still in. So on day 4, patient pacing has been taken out, and all of a sudden you got a call that patient is very restless, patient is hypotensive, cold and coming, and he has drained 1 liter, dumped 1 liter in the drain. So what to do? So it looks like there's a massive hemorrhage after removal of the pacing wear. So call for help. The first thing we'll do, the call for help and activate massive transfusion protocol. So what are there in the massive transfusion protocol? That means immediately you get O negative blood, 4 units, and also get 4 FFP and platelets. And so you activate that. And preferably you need 2 persons, 2 specialist person, doctors, and one will assess the bleeding of the patient, whether it's a major or minor bleeding, consult or revealed, anemia, tachycardic, thready pulse, hypotension, CNS, altered sensorium, in shock, skin, cold, cami, urine output, everything. And because the patient is day 4, apart from a peripheral line, all the lines have been taken out. So that's another problem, but you treat this patient. So while other person is prepared to treat the patient, what you do, you attach the basic monitoring and temperature probe is a must, and put a large bore peripheral line, sometimes difficult with a collapsed vein. So if the veins are collapsed, you can use ultrasound to guide your peripheral line, or alternatively, you have to put an ultrasound guided CBP or a big introducer seat like 8 French or 10 French. And very much need, I mean, it may be possible that you have to use ultrasound to put your arterial line because artery may be collapsed. And immediately arrange the rapid infusion system with the warm infuser, arrange cell saver, and send point of coagulation and a blood gas immediately. So this is how we manage the patient and volume and everything. So now, how much hypovolemia and how much fluid to give? That's the question. So how do you assess that then? So once you have done everything, you have intubated the patient, you can see the blood pressure is really low. You have also inserted the PA catheter because patient had a lung fibrosis. You don't know how much fluid you can give at one time, even not flooding the lungs. So upon doing all these things, you see that the PA diastolic pressure, which is kind of ALA pressure, is very low. So you can safely give the fluid based on the pulmonary capillary wedge pressure. We accept around 12 of pulmonary capillary wedge pressure. You can give fluid and blood, whatever. So you're not causing any pulmonary edema, and make sure the temperature of the patient is all right. And once we do that, other person will probably do an echocardiography for this patient, transthoracic echo. So you can see the heart is floating. So there's a lot of effusion around the heart, and you can see big pleural effusion also can see. And the patient has dumped 1 liter, so still a lot of blood up there inside the heart and the pleura. And also, don't forget to check the pleura. You can see the collapsed lung with a big effusion, and in the right side also you can see some degree of pleural effusion is there. So once you do the echo, if you're doing the TOE, if you see the LV, it's collapsed, the papillary muscles are kissing, and you have a very low endostolic area of the LV, then that means the patient is hypovolemic. And also you can use superior vena cava collapsibility index, which is a formula. If that is more than 36%, that patient is volume responsive. So as you keep giving the fluid, you have to assess up to what time patient will be fluid responsive. So SBC collapsibility, which is measured as SBC maximum diameter minus SBC minimum diameter by SBC maximum diameter into 100. If that is more than 36%, that means patient is fluid responsive. Alternatively, in spontaneously breathing patient, you can do Ivc Distensibility Index, which is nothing but Ivc maximum diameter minus Ivc minimum diameter by Ivc minimum diameter into 100. If that is more than 18%, that means patient is fluid responsive. Alternatively, if like see this patient, so this patient, to maintain the blood pressure, lot of vasopressors have been used, and you still don't know how to manage this patient, so you have inserted the PICO at the last resort. So for the PICO site, GDI, which is the Global End-Diastolic Volume Index, and ITBI, Intrathoracic Blood Volume Index, which is the marker of preload. So these are very low. That means patient needs fluid. At the same time, cardiac index is 1.7. That means cardiac output is low due to low fluid, and SBRI is very high. Anything between 1440 to 1660 is the normal cutoff of SBRI. It's 4,200. That probably you were squeezing the patient too hard with NORAD and vasopressin or whatever to maintain the blood pressure. So what you should immediately do, give fluid, and reduce the NORAD and vasopressor. So the end result after some time giving fluid, you see the GDI has improved and more than 13%, and ITBI has also improved. The normal value of GDI is something like 660 to 800, and normal value of ITBI is 850 to 1000. So it's still quite low, but you see the cardiac output is improving, and SBRI is decreasing as you are reducing your vasopressor. And other thing, but very important for this patient, lung fibrosis, you have got the lung water. So this is ELWI, extrathoracic lung water index, which is normal value is 4 to 7%, and PVPI, pulmonary vascular permeability index, normal value is 1 to 3%. So if you exceed 3% of PVPI, that means you are flooding the lungs. That means you are causing pulmonary edema. And so if these are green, so these numbers are fine, just give volume. No worry whether it's a pulmonary fibrosis or whatever, give volume, improve your cardiac output, reduce your SBRI, and patient will be fine. So that's it. Thank you very much for kind listening. Thank you.
Thank you, Arup, for that excellent presentation of how to manage a bleeding patient. You also touched upon the echocardiographic evaluation and taking help of the hemodynamic parameters, how to sort out the bleeding patient. Thank you so much. And we now go on to the question answers and panel discussion in the next 20 minutes. I think we'll finish that. May I request all the panelists and moderators to be online with videos on, please. So there are a few questions on the chat box. What I'll do is I alternate the panelists' question with the chat box question. So we will cover both of them. To start with, I'll request Dr. Sampada Gupta to tell us if they use in their center any risk scoring techniques for estimation or prediction of bleeding in a given patient undergoing major surgery, be it cardiac or non-cardiac. Is Dr. Sampada Gupta?
Yes, sir. Actually, for predicting the post-operative bleeding, it is very much essential to understand the complex array of the hemostatic insult that occur as a result of surgery or extracorporeal circulation for individual patient before selecting an appropriate coagulation or hemostatic monitor for the surgery. In my setup, we start the assessment from the OPD department. It is because that patients are taking very types of medication, especially they are taking the antiplatelets, anticoagulants, or the complementary medicine. So if it is positive, then we have to manage as per evidence-based guideline. Now, the bleeding history is very much important, which is to be taken out, including the personal history of bleeding or excessive bleeding, family history of bleeding, which is very much important for the pediatric patients, and the comorbidities which increase the bleeding risk, like the bone marrow disease, renal or liver disease. If it is positive, then we have to use the bleeding assessment tool or refer to the appropriate specialist. If negative, then we do the routine coagulation test like PTT, APTT, INR, ACT, and optimize for admission. After admission, it is done usually before 3 days. We start point of care coagulation testing, which include the ACT, PT, APTT for functional measurement, and take or Sonocloth for viscoelastic measurement of coagulation. We don't follow any stick to any scoring system. What we use the Sonocloth TX or ACT from the first day, and we do the serial monitoring. We have the Sonocloth accuracy near about 70 to 74%, at the take 80 to 85% to predict the post-op bleeding after cardiac surgery. And it's to mention that there is no comparison of the take with the Sonocloth. It is likely to reveal that the significant no advantage of one over another, as both measure the dynamic elastic of the homeostasis. So this is done in my center. We could not stick to any risk scoring system for the post-operative bleeding assessment.
Thank you, Dr. Sampada Gupta, for
Yes,
that highlighting the technique you use in your center. Anybody would like to answer? Add any points to this? The panelists or the speakers? Anybody wants to add any point to this?
Yes, sir. Puja.
Yes, please go. Can we have the videos on, please? Remove this advertisement. Yes. I want to see the speakers live on this screen. Please carry on.
Yes, sir. So just to mention about 2-3 scenarios in cardiac, especially when we come across. One is when there is a bicuspid aortic valve. So because any congenital defect of the aortic valve, because of the shear stress of the blood movement across the valve, we have observed that the factor fibrinogen is very low. So in our center, routinely pre-op, we do baseline fibrinogen levels, and based on that, we will assess the fibrinogen eventually with the ROTEM if there is massive bleeding, and we will give cryoprecipitates. That's one point. And second thing I would like to mention is about any VAD, that's ventricular assist device. Yeah. Whenever that is placed in the body, what happens is the blood is continuously moving in and out of it. So we have a von Willebrand factor deficiency, which is very common in that. And patients also have bleeding because of these arteriovenous malformations in the GI system because of the VAD itself. So we have to keep that in mind. And when we are doing such surgeries, especially VAD surgeries in non-cardiac with non-cardiac cases, then we have to have a baseline value so that we can work on it if there is a bleeding. So this is what I would like to highlight.
Thank you for your comments. Arup, do you have any scoring system for these patients? Do you follow anything like that?
No, sir. It's we don't follow any scoring system. It's,
right.
Because so many factors involved.
Yes, actually, this is ineffective. Yes.
And if you think like patient may bleed and we have restriction for giving a lot of fluid to the patient, then probably we take more care of that. And we don't routinely do the fibrinogen level for any patient, but if we suspect anything, we do the fibrinogen with a close fibrinogen, because the total fibrinogen level, it doesn't guide you a lot, honestly. So close fibrinogen is the functional fibrinogen, which is the actual number. So if that is all right, then you can be guided by that.
Actually, yes.
Sure. Thank you, Arup. Can I have the faculty seen on the screen, please? Anybody from the logistics? I would like to see the faculty on the screen. The question from the chat box is leukocyte reduction reduces CMV, but not really helpful in prevention of infection. Anybody would like to take the question? Any of the speakers or the panelists?
Yes, sir. Leukocyte reduction filters, if the size is less than 40 microns, maybe technically this English, it reduces the transmission of the infection. That is the reason why we are using a leukocyte reduction filter in patients who are already having infections. So that is the cause how it prevents the infection also, because it reduces the transmission. Definitely it helps in preventing the infection.
Anybody else who wants to add any point on this? Actually, leukocyte reduction is effective in preventing some of the adverse reactions, such as fibrin reaction, and also it reduces the HLA and platelet antigen immunization, and reduces the risk of CMV infections. And there is evidence in the literature to show that the bacterial proliferation also may be prevented by leukocyte reduction. Now we'll go on to the second panel question that is directed towards Dr. Anita Shinoy. Do you use any blood conservation techniques in your center? If yes, what is the technique you use and in which conditions do you use it?
Blood conservation techniques, I think in earlier days, we used to use for major surgeries such as scoliosis, we used to use what is called acute normovolemic hemodilution and induced hypertension. They have gone out of date now, so we don't use hemodilution anymore. Hypertension, induced hypertension, we are not that aggressive now because of the worries of hypertension and its own problems. So I think it's more of prevention that helps. Tranexamic acid is a very popular drug now, and so that is being given for all surgeries where we expect large blood loss. I'm talking in terms of all non-cardiac surgeries only. Yeah.
Yes, that is fine. That is fine.
Yeah,
you can.
Yes. So better surgical techniques and things like, day-to-day things. Avoid hypertension, avoid hypercarbia, avoid hypothermia, avoid hemodilution in terms of liberal fluid therapy. Those kind of things are given much more attention, and and of course our trigger for transfusion also has lowered now. So we don't pick up blood bags as easily as we used to do earlier. So that has definitely reduced the transfusion rates. We don't really use cell saver, probably because our patients don't bleed that much, not that kind of surgery that happens. That's why. Yes, sir. Attention to positioning of the patient, so basic techniques. That's what we use. The surgical techniques are also a lot better now with the cautery and the harmonics and hemostats that they also use, as was mentioned. Yes, sir. So we can't hear you. You're muted.
Can I have the faculty members seen on the screen? I want to see them face to face. Yes. Thank you. I got it. Thank you. The next question is from the chat box. Can we have the chest cavity packed?
Yeah.
Or the mediastinum packed, and then sort out the bleeding problems at a later time? Is that a good technique? Any of the panelists or the speakers can take the questions.
Yes, sir. It's the same thing what is covered in the post-operative period. A pressure dressing sometimes helps. If it is a generalized oozing, sometimes the pressure dressing helps. But if it is a patient is bleeding surgically, then also the pressure and shifting to the OT and looking for exact bleeding vessels and tying it up definitely helps. It get covered under the pressure dressing in the post-operative period.
Yes, yes, yes.
That's very common for liver injury and splenic major laparotomy. That's very common to
yes,
do
yes.
packing and coming back, relook later, about 24 to 48 hours later.
We do the same for cardiac surgery. The patient is oozing and we are not able to tackle on the site. We pack the chest and then get the patient back the next day, and invariably, the bleeding would have subsided by that time. Do you agree with that, Puja and other participants? Arup?
Yes, yes, yes.
Yes, yes.
Sir, it has to be based on ROTEM. We have ROTEM in our institute. If the ROTEM is normal and our post-op, all our coagulation parameters are normal, and definitely the packing will help. But if those are abnormal and still we are looking at packing, I think within an hour we'll shift the patient back.
Okay, let me turn the question a little bit. Did you have any situation where all the parameters were normal, but the patient was still bleeding?
Yes, yes, many a time, sir. Yes, 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 it does happen.
Now I'll go on to the next panel question that is directed towards Dr. Rekha Das. In a non-cardiac surgery setting, how do you manage intraoperative bleeding, which is uncontrollable? Do you follow any algorithms for that? In a non-cardiac surgery,
yes.
For example, you have
yes, yes, sir.
Yes, yes.
So this is for a massive blood transfusion. I think we're talking about when we are having a uncontrollable bleeding or a significant bleeding. Okay.
Yes.
Having said about the side effects of transfusion, definitely in a massive, you need to have a massive transfusion protocol in this situation.
Right.
But the general formula is to transfuse RBC with FFP and platelet in the ratio of 1:1:1, as said by Arup, which also extrapolates to non-cardiac surgery also, where we give 4 units and then we equally give an equal volume of fresh frozen plasma and platelet. Right. But it would be prudent to go for an intensive monitoring in these situations, because we also understand that some of our patients are comorbid and some of them may not tolerate the anemia to a great extent, and we have to also look at the ongoing blood loss that is taking place. And so we need to do an intensive monitoring of these patients by looking at making a visual assessment of the surgical field and the standard assessment methods for quantitative measurements, like looking at the surgical sponges that have been used up, the blood that is in the suction canister and in the drains. Okay, and then we need to also, when we are transfusing, we also need to look at the perfusion of the vital organs, like the urine output, which are the most basic, the vitals like the blood pressure, mean arterial pressure of 65 we need to maintain, and the heart rate also. We should see that if the patient is tachycardic, even if the volume appears okay, then probably we have not replenished adequately the pulse volume and the peripheral oxygen saturation. We also need to do some point of care testing like a blood gas analysis, which will not only tell you about the hemoglobin that the patient can tolerate, maybe 7 to 9 grams, but also what is the partial pressure of oxygen there in it, and the pH, which is very important, which will tell you about the oxygen extraction that is taking place. Okay, if the pH is less than 7.2, it is very important that probably what we have done, the replenishment is not enough, the anemia is not really corrected. And also, if it is possible, we can go for a mixed venous oxygen saturation. And as pointed out again by Dr. Arup, that if you have a facility for a intraoperative echocardiography, then we have really a blessing in us, with us, like we have the opportunity to do that, and we can do again. That is also a point of care testing when we know how much to transfuse and how much of hypovolemia the patient is having. So having done all this now, sir, you were talking about the algorithm. Well, then that calls upon the algorithm approach is actually a goal-directed therapy, which is based on the viscoelastic method, which has already been pointed out by Dr. And nothing, and to highlight this, we need to have a ROTEM facility, which we really do not. In our institute, we do not have a ROTEM facility, but nonetheless, whenever a patient is bleeding, for people, this is for people who do not have a ROTEM facility, I would like to highlight, you should first consider hyperfibrinolysis in this kind of situation. And it is better to treat them with tranexamic acid with a dose of 20 to 25 milligram per kg body weight. And then If the patient is still bleeding, we can consider fibrinogen deficiency. And if we have access to fibrinogen, we should give this patient at this time fibrinogen concentrate at the rate of maybe in a dose of 30 to 60 milligram per kg body. And then third thing we need to consider here is a thrombocytopenia, which the patient could be having. And if we have access to a platelet count being done, but in a very close by laboratory, which many in our setup, we are having one inside the OT itself, near the OT, adjacent to the OT, where they do an instant count, and the qualitative and the quantitative assessment they also do. And if the quality is good and the count is or less than 50 or something, or in a neurosurgical procedure, if it is less than 1 lakh, then we would go for a platelet concentrate and one pool, and then again reassess, and then we can go for a second pool. And then after all that, if the patient is still going on bleeding and there is a loss beyond 1.5 liters still continuing, then we can think of other coagulation factor, that is the thrombin deficit. And if we have access, we do not have access for this, but if we have an access, we should go for a prothrombin complex concentrate. And that comes in a dose of 20 to 30 international unit per kg. But if we do not have, so we have a poor man choice. So it is a fresh frozen plasma in a dose as high as 30 milligram ml per kg. And then after having done all this, if you still consider that there is a need for transfusion, we are losing out on something and the patient is still bleeding, and then we can think of the fifth factor, that is the factor 13 deficit. And which indicates that probably the patient has clotted, but there is an instability in the clot. That is, the fibrin monomer is not going into a mesh, it is not forming a mesh, and so there is, it is not related to hyperfibrinolysis, but there is this is probably occurring in a diffuse blood loss where there is a clot instability, and there you need to give factor 13 concentrate. And again, if you do not have factor 13 concentrate, which we do not have in our center, we go for a FFP. So that is the layman algorithm that we follow in our center. So.
Thank you so much. Maybe you must, maybe we should think of writing this up in a resource limited environment, how to manage bleeding. Maybe we should write it up, which may be beneficial to some of our brethren in the country who work in limited resources. Thank you for that input, and we really appreciate the way you manage the patients.
Regarding one thing to that, sir.
Yes.
What Dr. Das has told. So you can check the calcium. Calcium is also very important.
Yes, I forgot that. In addition to all this, we need to look at a few more things, that hypothermia, we need to look at the acidosis, and we need to look at the hypocalcemia that the patient could be having. And anemia, of course, is an issue.
Right.
I forgot.
Thank you for that additional point. Arup, I would like to make one comment and ask one question to you. The comment is that you put all the facts. When you started the lecture, you were saying the facts. What are the facts? One more fact is that bleeding occurs from cut blood vessels. Bleeding occurs from cut blood vessels. Otherwise, it does not happen. So the surgeon is the culprit. He cut the blood vessels, and that's what. I'm in the lighter vein. But my question to you is, you mentioned aproteinin in your presentation over a couple of times. In Europe and in your center, do you use aproteinin even now? Are you using it because it has a red label and we have stopped using for the last 10-15 years?
So thank you for the question.
Please don't put this advertisement. I want to see the face of the faculty. Please, after the talk is over, you can put it. Yes.
Thank you for the question. So it's a very interesting question. So the red label or black label was put by FDA, which is the American Drug Association, which does not, the UK and Europe doesn't fall under that FDA. So in Europe, it's still very much predominantly, aprotein is still predominantly used, particularly in transplants, lung transplants, heart transplant, liver transplant, infective endocarditis. And interestingly, we had a study, let's say, and not Nordic style trial. I think the results will come soon. They studied with multi-centers with Europe, and they have found the risk is really low. So I think in a couple of years, aprotinin is making a strong comeback, and it's an excellent drug. I mean, if you use aprotinin, it reduces the blood loss really significantly. And I think in India, if you have aprotinin, you can use, because you are not under FDA. And
Yes.
it's a fantastic drug. And the only thing is that, so you need to give a test dose for using this aprotinin. And we give a bolus of 2 lakh unit, 50,000 into 2 lakhs unit bolus, followed by 50,000 unit per hour infusion till you close the chest or till you are nearly at the end of surgery. So that's it. No post-operative, nothing. That is aprotinin. But I think it's a very, very potent drug to reduce bleeding in high-risk patients.
Thank you for that. And there are 2 more questions before we wind up for the day. I'll just quickly go through that. What is the role of fresh whole blood? Do you use in acutely bleeding patients? Any of the panelists or the speakers can answer this question. Do you use fresh whole blood for acutely bleeding patients?
Fresh whole blood has a role in trauma.
Right.
It has a role. Warm, fresh whole blood has a very good role, has a definite role in trauma settings.
Yeah. I always argue with my colleagues saying that we should use fresh whole blood, because when my patient is bleeding, he's not only losing the RBCs, WBCs, but also he's losing all the factors contained in the blood. Why not you give everything together in the fresh whole blood rather than give one factor at a time? I always argue with him, and I always tend to lose the argument, because they have some great ideas about the usage of factors separately and treating the coagulation problem in a particular patient in a particular way. So the next question is, what are the criteria for the use of prothrombin concentrates? Somebody, I don't know the name of the person has put it. What are the criteria for the use of prothrombin concentrate? Anyone can answer that? Speakers or panelists?
Yeah, so prothrombin concentrate mostly, contains 2, 7, 9, 10, C and S. So basically, you can use it pre-op if the patient is on warfarin for warfarin reversal, and also reversal of some drugs like dabigatran and apexaban, all these drugs which increases the INR. And intra-op, we use it deciding upon the INR and clotting time of the extent. So if the INR is in cardiac surgery, I correct it, anything more than 1.3, but you can anything more than 1.5 with a clotting time more than 80 seconds, then PCC is a very good choice to correct the coagulopathy.
Thank you, Arup. I think I'll ask the last question to Dr. Swapnil. What's the role of factor 7? Do you use it in your clinical practice?
So factor 7 is definitely available at our center. The thing is, the prohibitive this cost is almost 1.5 lakh, if I'm not wrong, per a single dose. Right. So I remember using it in a couple of patients who were sort of had a blood loss excess of 30 liters in a cancer surgeries. And these patients were packed during the surgery, and post-operatively we were monitoring the intra-abdominal pressures. And on second day, we administered factor 7. It definitely helped the patient. A couple of days later, we could remove the packs easily. So not a vast experience, but we have used it in a couple of cases.
Thank you, Swapnil, for joining us. And I think it's time to wind up because it's dinner time now. And may I request Dr. Sanil or Dr. Radhakrishnan to say a few vote of thanks. Dr. Sanil is available. Radhakrishnan is available. I don't know. Dr. Radhakrishnan, Baljit Singh, Jayashri, one of you can say vote of thanks, please. We had a lovely session. Actually, we went through the physiology of coagulation, conservation techniques. We went through blood conservation, then how to test the coagulation problems intraoperatively by using viscoelastic tests, and how to manage the patient who is bleeding. All the topics were covered in a very efficient manner. Thank you so much for joining us. Dr. Radhakrishnan is available?
Yeah, I am available.
Thank you, sir.
Thank you.
I request you to propose a vote of thanks. Say
you,
some concluding remarks.
Thank you, Murali and the team. This is a wonderful webinar. You were able to really expose the subjects and is equally useful to all. I mean, practitioners, students, as well as we faculty members. It was a really good webinar, probably one of the best we had in the recent times. Next, we will be meeting the same time and we will be talking on thoracic anesthesia, especially not thoracic anesthesia, certain parts of thoracic surgery and anesthesia, especially on the double domain obesity study and the current use. And basically, we are going to deal on the optimization, the pharmacology and the physiological optimization before surgery. Right. That is planned for the next week. And I really appreciate everybody, and I thank all the faculty members in joining this particular webinar, as well as all the persons who attend the webinar. Thank you. Good night.
Thank you so much. Thank you to everybody.
Good night, everyone.
Thank you, Balji. Thank you for joining us. Thank you so much.
I was there all through.
Thank you, sir.